And welcome back to the Contemplative Science Podcast. My name is Jamie, and as always, I'm joined by co-host Dr. Mark Miller. Mark, how are you, man?
Hi, Jamie. How's it going? I'm doing very well, and I am especially excited for our episode today because we're talking to one of the teachers that I follow really closely. So it's going to be a great podcast, I think.
Yeah, today's exciting. Today our guest is, of course, Daniel Ingram. Daniel is a medical physician, the author of a number of excellent meditation books, including Mastering the Core Techniques of the Buddha, and he's the founder of meditation social network group, the Dharma Overground, and more recently, the leader of an exciting new research group, the Emergent Phenomenology Research Consortium. Daniel, hey man, how are you?
Hey, I'm doing great. How are you?
Very good. Thank you for being here. It's great to chat to you, and there's lots to get through, so I'm going to jump straight in. Today, we want to speak mostly about the Emergent Phenomenology Research Consortium, which you recently founded. Now, its stated mission, this is the interesting thing, is to bring together clinical, scientific, and spiritual paradigms to improve clinical outcomes. Now, before we get into why psychiatric care of any nature is sometimes required for those pursuing meditations, we'll start with the practices themselves. So you've said, and I'm quoting, that most people doing emergent practices and other activities likely to yield emergent phenomena have little idea of the full range of experiences and effects, both good and bad, that these practices may produce. So I have to ask off the bat, when you talk about emergent phenomena and emergent practices, what do you mean?
Well, that's a good question. Actually, I'm going to step back just slightly to something you said earlier. So in terms of the EPRC, it was founded by a bunch of people, actually. This is a very collective effort with a lot of extreme enthusiasm and diligent people who have been working for years on putting this thing together. So just to make sure we properly distribute credit to this remarkable team of interested and engaged people. So that's the first thing I wanted to do, just to be really balanced and fair in our journalism here. But in terms of like what are emergent phenomena, or what are we calling emergent phenomena, if that's the question. So then what most people would think of as spiritual, mystical, magical, psychedelic, energetic phenomena. So first to sort of broaden it out into those kinds of categories. But this can actually encompass an extremely wide range, from curious physical effects like muscle tensions and movements to perceptual effects like suddenly feeling your body vibrating rather than being solid, existential effects, changes in the sense of who one is or is not, personality effects, changes in preferences, feelings of renunciation or high degrees of engagement with life, changes in the sense of even what experience is, what consciousness is, the sense of, is consciousness everything? Is consciousness nothing? Is everything full or empty? Is everything divine, or is does nothing actually exist? These are experiences and paradigmatic shifts that people can go through, as well as experiences at each of the sense modalities, from seeing lights or images to hearing things, voices, songs, music, smelling things, incense, other strange sensations, odd, curious distortions of perception, even if there isn't anything obviously new added to it, the sense of the body dissolving through the floor or rising into the air or going to other dimensions, or full-on experiences of contact with other entities of various forms, and then all kinds of other stuff. So changes in vocation, attitudes about vocation, functional relationships, relationships to money and children and parents that can undergo some sometimes radically strong transformations. And these things have been described for thousands of years, so it's not surprising that they happen today as a result of the same techniques that they led to then across countless cultures. So that's sort of a short list. The longer list would be a lot more, but that hopefully will give us something to talk about in terms of a conversation. And obviously, these, for people who are not expecting them, can be pretty weird, right? And sometimes very disconcerting, and sometimes lead to them interacting with the healthcare system. And that's where things can get complicated, because in the list of groups that don't really know much about these, the mainstream healthcare system and mental health system unfortunately falls in that category. So we aim to help them to know more about these things that will lend value to care and help the public as well.
Yeah, it sounds spooky, right? When you think about how mainstream how mainstream medicine is going to interact with that spookiness. It's not a massive surprise that people run into trouble, and therefore it's not a massive surprise that something like the EPRC is needed. Obviously, people can have these experiences through emergent practices. That's what we're calling them. What is an emergent practice?
So we're again, this is one of these big sort of baskety categories that is everything from prayer and contemplation of spiritual and existential and philosophical truths to meditation, psychedelics, various forms of retreat, intense exercise, sensory deprivation, float tanks, psychedelics. There's all kinds of situations that intentionally might lead to these, where people doing yoga or qigong or various movement-y sorts of practices, sleep deprivation, fasting. There's all kinds of ways that people have traditionally and in contemporary times attempted to get into these, right? So you have the intentional practices, and then you have the unintentional things, like during birth, during intense experiences, during periods where attention is extremely highly trained on some situations, such as even in wartime or even intense sports, or coming down from space. There are a number of astronauts that have reported this coming down out of space. So various situations that bring people far outside themselves, like these, people go to Burning Man within a few days can seem utterly different than how they were before, for example, even if they aren't partaking of large amounts of plant and plant-based and synthetic substances. And it's just because of a change of environment can start shifting fixed senses of perception of how things are and how one is and the relationship between these things. And so there's a whole lot of circumstances. And then sometimes it's not obvious why people get into these at all. I know people who've reported these kinds of effects just walking down the street, for example, when they had no obvious contemplative practice. It was just somehow the magical convergence of unknown factors that we need to explore came together, and all of a sudden they were in very different territory.
Yeah, Mark, what's the thing about becoming accident prone?
Yeah. Right. So, I mean, if part of what we're doing on the mat with these different practices is we're opening ourselves to a new way of experiencing. I've heard some people say before that sometimes that can just accidentally happen. I mean, you don't necessarily have to be practicing for years to have some of these spooky emergent phenomena occur. For some practitioners, they practice in order to make themselves accident prone, in a way where you put yourself in the best possible position for some of these emergent phenomena to take place.
Are they
right? And it can actually, if you don't mind me just adding a quick thing there, it can even cross way out of the realm of accident and into the realm of intention. Like,
Indeed.
A lot of these are learnable things that you can learn to get into with mastery. So in a sense of competence and predictability to them rather than as accident. So for a lot, they start as accident. And for them, some may go on to cultivate the level of technical control that is described in like lots of those books, for example, and lots of others. Anyway, and so you can move from accident into competence and from competence into mastery. And just make these things just part of what one can do or experience.
Sorry, James. One of the things that sort of comes up for me just hearing you speak is human experience is so wide. I mean, there are so many weird and wonderful ways that we can experience our bodies and our space and who we are and what we are. And those are all going to come to different degrees by these sorts of emergent practices. But the emergent practices list you just gave us is huge. I mean, you included in there prayer and exercise and yoga. And of course, today, lots of people are doing meditation, lots of people are doing yoga, but I don't know how often we're talking to experts who know what emergent phenomena is all about and how to navigate the space of emergent phenomena, even though, you may be engaging with practices that are going to be those kinds of things that pump or generate those sort of emergent phenomena. So that seemed to me like a potential storm, a potential sort of perfect storm. We've got lots of these practices. We're attracted to these practices because something in us is calling us to be doing these kinds of practices. And then there is this probably inevitable to some degree, different emergent phenomenology, but with not as, well, at least I don't think, we don't have a very good conversation open right now. At least it's not very popular to be talking about this sort of emergent phenomenology.
Yeah, it's definitely true. And that's a real problem. So I think that if you're going to scale these things ethically, you have to have a healthcare system, and particularly a mental health system, that has a relatively sophisticated understanding of these, and not just of the common unusual things that can happen, but some of the rare things that can happen. Because like, let's say you taught meditation to, say, 1.2 million children in a public school system somewhere. If only, 1 in 100,000, if, let's say you say these things are that rare, well, you're still talking about 12 kids or whatever, which is a non-trivial number to get into strange territory. And so, just like in medicine, we study all these very rare things. We studied hundreds of conditions that I never even saw after seeing 60,000 patients. And yet we still, thought we need to know something about those, even if they're quite unusual. I don't think these things are actually that unusual. But even if you argue that they are, just as we list all these rare side effects of what Tylenol, or paracetamol, as you might call it, if you read the fine print of what this can do to you, you'd be like, really? You might be wary about taking it. But, I take Tylenol. It's generally fine. So in the same kind of way that medicine thinks we should know the minutiae, we should know the rare things, we should know the unusual occurrences, and we should know something about their underlying physiology, what's bad about them, what's good about them. That's the other interesting thing. What are the transformative potentials of these sometimes strange experiences? Because, there are whole religions that are based on the notion that these could be some of the most valuable, healing, and transformative things that there are. And so that sort of appreciation of the range of highs, lows, weirds, good, bad, and strange, that's something the clinical mainstream currently lacks. And then the problem is getting them the level of data quality, the epistemological weight of evidence that lets them think, okay, there really is a there, and we have some functional working understanding of it that we can trust. That's really what the EPRC project is about, is then raising all the money, finding all the scientists, designing all the studies, taking all the time, and doing what we think will be generational level change of an upgrade of the healthcare system based on just really high quality science that is not trying to say rah meditation or psychedelics, or try to say all the stuff is bad or all it's just crazy, but actually something much more nuanced that can handle the good, bad, and the ugly, and just look at it in a very neutral, balanced way, such that you can really meet the core criteria of medical ethics, which are informed consent. And informed consent means you have high quality data to inform a conversation about risks, benefits, and alternatives, not only of cultivation strategies and practices, but also of underlying frameworks for even how you look at this stuff, for diagnostic and management strategies. And then once you have diagnostic and management strategies, you can do epidemiology and public health resource allocation and national health policy and all of the stuff we want. And so that's what the EPRC and the charity that I spend a lot of time building and helping to run, called Emergent's Benefactors, which is designed to raise the hundreds of millions of dollars this project will take. And so that's really what the whole EPRC project is about.
And, I'm interested in the phenomenology here, because when people have these experiences that are somewhere on the spectrum of good, bad, weird, it might be that it's difficult to have language associated, because we don't commonly describe these things. How are you going about the problem of, okay, people have these experiences, but they're different for me and you, and also you might use totally distinct language that I might?
Right. So the linguistic problem, I think, is actually one of the most critical, because this previous attempts at this, we're not the first people to have attempted this, obviously. There's a long line of them going back to William James in 1902. And so there's 120-ish years of people trying to figure out how to upgrade the understanding of the clinical mainstream through careful description and phenomenology. So if those in your audience take the time to read The Varieties of Religious Experience by William James, you'll be blown away at how unbelievably good and detailed and thorough and careful and nuanced in its consideration of ontologies and everything it is, and yet there's nothing of it in the clinical mainstream, which is a tragedy. But all the other studies and things that were needed didn't happen, and some of its language doesn't really scale or doesn't really work. And so the linguistic considerations, first, just figuring out how to teach people a language of phenomenology. So I think in order to get this right, we're going to have to use existing clinical terms that already exist. And also, I think, stick to relatively simple terms that have very little ontological overlay. So, for example, and really think carefully about what scales across religious settings, across secular settings. So I think there are a lot of words so for example, the transpersonal literature has been attempting this for, 50-ish years, something like that. And yet I will assert a lot of their linguistic choices didn't do them a lot of favors when they were trying to scale into, say, heavily Catholic or Muslim or Protestant or whatever countries, because it had sort of a religious tinge to the language that just wasn't going to work. And so one of the what we have people who are anthropologists, and we hope to have linguists, and we have computational linguists and people who can help us figure out the language to keep it as neutral as possible, as clinical as possible. I am unbelievably jealous of chemistry and physics and mathematics, right? Taxonomy, just biological taxonomy, these disciplines where a lot of the language, there's some debate about around the periphery, but a lot of it is relatively straightforward. And so making sure we give clinicians and the public straightforward, very neutral, simply descriptive language. And that's why Emergent Phenomenology Research Consortium, it's that phenomenology piece that we think will help scale it, as well as staying away from ontological debates. So a lot of the people in the space are like, we must, prove that consciousness primacy is the most important thing rather than material primacy as the underlying stuff of whatever. To use an example I use all the time, I don't know what a migraine is. It's something about vasodilation and calcium channels, but I got really good at diagnosing migraines based on clinical presentations and people's simple descriptions of their migraines, which can do all this weird stuff, wiggly lines, perceptual distortions, look like strokes, all this memory changes, personality changes, all this bizarre stuff, and paralysis, and yet, okay, that's probably a migraine. And then, I don't know what it is, but I actually got good at diagnosing and treating it. It's that kind of practical competence that we think we can get in the hands of the public and ordinary clinicians to just figure out, hey, when this weird thing's going on, how do you deal with the strange, the bad, and cultivate the good that might come from it, and do that in a very straightforward way. And so even though, and a lot of people have said, well, even the clinical mainstream clinicians, if they haven't had these experiences, they won't be able to diagnose and manage them. But I've never had a migraine, yet I got pretty good at diagnosing and manage them, I think. So anyway, yeah.
At least half of the work here
Sorry,
seems
I do go
to be
on, don't I?
Oh no, it's great. It's perfect. It seems like at least half of the work is getting practitioners to have a language to understand, to be able to better articulate the sorts of things that are happening to them. Where do you see, where does that education come in? I mean, if somebody is coming up to just do a sort of very light sort of mindfulness-based pain reduction course, should they already be looking forward to taking a kind of module to be able to discuss emergent phenomenology? Or is this maybe kept aside until people sort of get into their practice in a more deep and more comprehensive way?
So the problem is contemporary medical ethics basically mandates that you should talk about it ahead of time, or should make that information available and even tell people that these are possibilities. And so because, like the warning labels in paracetamol or Tylenol, right? So even if it's rare and unusual, we make sure, hey, if you want to actually know what can happen from this, we give you that information. We treat you as adults with respect. And I think medical ethics does not, at the moment, contemporary medical ethics, at least as I was taught it, does not support the notion of hiding the ball, saying, oh, we know best, we're going to make these decisions in sort of a parental way for you, kind of a paternalistic way or maternalistic way. And then we're going to, assume that this is good for you. And some small portion on a low dose will get into this territory. And they won't have known anything about it or had the right to give informed consent. But we'll take that as a risk that we think is better because we're making this decision for everybody. And I don't think contemporary medical ethics really supports that. We could have a debate about that. So, and there may be utility sometimes in just making decisions for people. So this is a debate that's been going on in medicine and even in certain societies, right? Where, the degree of, which the doctor or the psychiatrist is just considered right in their judgments, or establishments are just simply considered right in their preloaded judgments about what you should do or not do, know or not know, right? And what information they should hold back and what information they should give you. But I think in most contemporary ethical discussions, I get the sense we lean more towards real informed consent, which involves a high degree of information about risks, benefits, and alternatives. What are your thoughts?
Yeah. Is there a worry here, though, that being as preemptive as you are in medical ethics, in contemporary medical ethics, might be predictive of weird experiences. I mean, is it possible that I find out about all this phenomenology that might emerge out of a meditation practice, and then because I kind of have heard of it, slightly induce it or am more likely to run into it?
Well, that's actually an extremely interesting hypothesis. And so since we don't know, we don't have definitive studies on the answer to that question, and how much is scripting, how much is expectation, and how much is almost like attunement. Like if you know something's there, maybe you can tune into it, right? And so which is actually empowering, which is damaging, and how does all that work, right? So the placebo and nocebo effects of how you describe the positive and negative effects of meditation. This is actually something that I don't think is well studied, and is actually a vital question. And so really what I would like is even better than my expert opinion, right? Because I have this bias towards more information, but that doesn't mean that's the right decision for anybody necessarily. And so what I would actually greatly prefer is what the EPRC hopes to do is you could actually do those studies. You could put forward the hypothesis. You could have comparative groups where you disclose, all of the stuff it could do, some of the stuff it could do, none of the stuff it could do, and you have people move forward. And then we could even debate, is it ethical to do those studies? Well, this is complicated, but you could move these trials forward. Perhaps if you could get an IRB to approve them, say we're not going to tell anybody anything about what these, we're actually going to pre-screen for the most ignorant patient population of the possible range of effects, right? And then you could see going forward what that leads to. And you could say, hey, this is the good stuff that comes from that sort of, the various approaches. This is the bad stuff. And then at least you can do what from medical ethics, again, I think mandates is have enough, to discuss the risks, benefits, and alternatives of each of those strategies of information disclosure.
Yeah, man. And then the other angle here is, say you were meditating with some kind of aim at getting mastery over these emergent phenomena. Well, maybe if you know what they are ahead of time, the prediction of them coming actually means you might be more likely to catch them and more likely to develop those skills just because you know what the clues are.
That would be my distinct impression. So if someone said you have to bet right now on which was true, more likely to gain mastery with or without the knowledge of what there is to master and how to master it, I would definitely, instantly, without question, bet high dollars on disclosure of what's possible, but not only in potential in terms of the good stuff, but also the bad stuff, and also technical strategies for cultivating the good and avoiding the bad, a heads up, ways to tune. And then, of course, I would bet on that as more likely to lead to these things, all things being equal. That doesn't mean that other people without that knowledge can't get into really cool territory. Sometimes they can, but it involves, it's like, people can teach themselves how to play the piano or the guitar, but on average, more people are likely to gain competence if they're taught, from people who figured out how to do these things beforehand, right? So it's not a surprise. But again, this is an important thing to study. So we actually comparing contemplative traditions that give people more or less information and then seeing what those things lead to. Absolutely. This is important.
Well, this conversation feels to me like it's leading in a way to think about a sort of radical revolution of how we practice and how we practice together and how we think about practice. Because I just can't imagine right now if we're going to include this rich landscape of phenomenology, and that, we start by saying it's ethically important that we understand that landscape and that we're with somebody who can help us understand how to navigate that landscape. I don't know how you would do that at a 10-day retreat or at a short course where you're not with the teacher ever again, or where you have no ongoing community with wisdom teachers that are available to know you and know your experience as it evolves. I mean, I don't really know how we're going to be able to navigate that rich landscape in the kind of way that meditation is starting to be delivered in these sort of bite-sized pieces that, you just sort of bump in and bump out of.
Well, I mean, they're definitely sort of relying on the notion of dose response, that less meditation leads to less weird, right? And I think in general that's probably true, though again, it requires more data to be certain of that. But that's been my experience and makes some kind of sense. Exactly. Obviously there's a wide range of dose response, but I know people who literally on their first sit ever in their life suddenly got into wild, powerful, energetic territory with bolts of energy and white light shuddering up their spine and radiating out into cosmic consciousness. Is it rare? Yes. But does it happen? Yes.
Right.
And so then the thing is, I think just as we have like in the world of clinical care, you have your your regular offices that can handle ordinary stuff. And then you have your urgent cares that can handle some more. And then you have your rural ERs, emergency departments, A&E centers that can handle some more than that. And then they usually know the regional referral center where they can get a really good surgeon, maybe orthopedics
right.
and whatever it is that
Right.
they, and then they usually know the tertiary center that they can send people to when they can't handle it, that's got the big stuff, the burn centers and the, all the fancy toys and the neurosurgeons and all that. And so just in that kind of way, what I think we need to do a better job of educating is people who are teaching this stuff say, hey, it's not common at the level you're teaching it or in the doses you're teaching it, but there is a non-zero number of people who might get into this territory. And so, obviously they will have to make their own decisions about how much to disclose. But what I would really like is if the people teaching it got some training in this and at least how to recognize it. I think you could even give people like a page or two and say, you see any of this? You need a teacher who's got an understanding of this that maybe you don't, or maybe they do. I don't know. Maybe some of these people teaching at low dose in these, places have some understanding because they've had some experiences themselves. Cool. But for those who haven't, recognize there is a world of this out there and then we need to create the specialists, the nurses, and, the advanced practice practitioners and the doctors and the psychology, and social workers, et cetera, PhDs and masters and all those people who somewhere somebody has some training in this at various levels of depth. And so creating that referral network. So even if that's not you, you know who to go. Everybody around here knows the big local hospital. And if you got something bad, you go to them and they have the people who know this stuff. We need an equivalent system and level of certification and training and specialty and all that, I think, for emergent phenomena. And we need to do that globally, right? To have that as a globally scaled thing, because medical ethics actually dictates a bunch of different stuff. Not only does it patient autonomy and, thus informed consent and risk benefits and alternatives, but also knowing enough to do good, knowing enough to avoid doing harm, because the problem is a bunch of my friends, when they have these things and have been unfortunate enough to run into the healthcare system, it can go pretty badly, unfortunately. And then, but also justice and equity. And justice and equity means a global distribution of that knowledge such that people around the planet, as people, have access to this sort of information and this kind of support.
What's the baseline ontology we're assuming here? So obviously we're not making any great ontological claims around the realness of, you made the point about consciousness earlier, but when we're referring to, the equivalent of like a regional hospital, if I rock up at a regional hospital and say, hey, I've been doing this meditation stuff and here's a bunch of emergent phenomena, am I needing them at least to sign up to the idea of, okay, well, there's emergent practices and there's a spiritual significance to those practices and here's a bunch of phenomena? Am I needing them to sign up to that level of ontology?
So significance to those practices. So all clinicians already operate at the level of symptoms, which is what patients tell them, signs, which is what they see, and then categories that they put that into. So that's already something they should be signed up to, is the range of human experience, just by being clinicians, right? And then that signs and symptoms might have implications for somebody's health and well-being and outcomes should already be something that all clinical practitioners are signed on to. So it's really just a question not of fundamental clinical paradigm, but of adding more stuff to that. So for example, Lyme disease is pattern recognition that didn't exist before some clever housewife or whatever in Connecticut was like, hey, all these kids have arthritis and all these kids got tick bites. Maybe there's a there. In the same way, lupus is a pattern, like it was all this strange stuff, but eventually you figured out, it's autoimmunity to your own genetics. That was a stretch, but you start to notice these patterns of disease. Kawasaki's, we don't even really know what it is or why. It's this strange thing kids get that causes heart valve things and blood vessels to blurb out, and it can do this strange stuff, right? And make them really sick and even kill them. We don't know what it is, but we started to recognize these patterns, and some people get named for this. They figured out this pattern. Well, we think in the same kind of way. There are well-described patterns that we see that can be grouped into taxonomic and then diagnostic categories that thousands of people, actually countless people over thousands of years across traditions have thought there are cultivation and management strategies, for the good and the bad that lead to benefit for patients. And so the notion of, I think it's really just a question of adding some diagnostic categories and adding those to the DSM and to the Chinese and Russian and Latin American equivalents and whatever else the rest of the world uses, and ICD-10 and 11 billing codes out of the World Health Organization and to whatever the rest of the world uses, right? Because not everybody uses those. And then getting these into protocols where clinicians can go, okay, you fit this pattern. We know from data that this kind of strategy adds value to care, and it can just be one more of those things that maybe we don't entirely understand what it is, but that doesn't mean we can't help you, right? Yeah. I think we can, and I think we can do better.
Wow. Daniel, where do you go to find maps to start building up the kind of knowledge resources that are necessary to get useful maps? I mean, I guess there are going to be ancient maps that we draw from, but I suspect that there's also going to be contemporary people who are passing through these various stages who are going to be able to comment, augment, adjust. But where do you tend to go to find the knowledge base for this sort of project?
Yeah, so that's what we call the state of the art project. And so the state of the art project is a huge project that wants to look at basically all of the major ancient sources that we can find, which is in a lot of different languages from a lot of different traditions, to get basically a list of their descriptive phenomenology, because there's a lot of phenomenology and their diagnostic categories, and then compare that to contemporary sources. There's a lot of contemporary literature that puts this into various categories, including the Groffs and Jack Kornfield and Christian contemplatives, and there's Sufi maps, Ibn al-Arabi, and there's all kinds of different ways people looked at this stuff, and then, some of my own work. But I think what we're going to end up doing is looking at all of that. And we have something called the Expert Opinion Project, where actually we're going to interview a whole bunch of people who have been helping to manage this stuff in their own traditions and through their own frameworks for decades. So the senior people in the field, and say, hey, what do you see? How do you think about it? What kind of categories do you put it into that then differentiate and dictate your management strategies? And then what kind of outcomes do you expect from those? And so those are the kind of, we're trying to find the money for that study now. So it's about $250,000, so pretty darn cheap as these things go, and going to be done by some really good people. And so, and in this way, through a lot of different sources, through ancient, classical, contemporary literature, as well as current practitioners across a wide range of traditions from a whole bunch of religions and spiritual disciplines that do this, and across countries and continents, and to say, hey, what patterns emerge from these things? And not only where are the areas of consensus, like maybe there's real consensus in how to ground people down who are on some kind of, edgy spiritual high. Maybe they all start saying the same things about diet and exercise, or
exactly.
Something. I don't know what
eat a cheeseburger, go to the
exactly.
garden.
Right, who knows? Well, maybe they're all going to say cheeseburger, right? And they all say, sorry for the vegans and vegetarians in the crowd. Maybe, who knows what they say, right? But maybe there are some areas of consensus, and those we can then identify the evidence quality. This is going to be by expert consensus opinion, right? And we can say to the clinical mainstream, hey, we have this level of evidence quality for this. Are you willing to adopt that? They may say yes. They may say no. There might be some debate and discussion. Okay, fair and reasonable. But then we also expect there will be areas of controversy, right? Between the old texts, new texts, and current practitioners in the field. Like, hey, how do we ground these people down? And people may be giving diametrically different advice, in which case that is really interesting. And that's where you can do hypothesis testing. And maybe in certain populations, one set of advice works, and another population, the other set of advice works.
It's culturally, contextually sensitive in some way.
Culturally contextual, even genetic. It's not like we're all the same, right? Who knows? Like, why is it that some people, you give them these practices and they just stay at the level of psychology and back pain, and other people, even small doses, they're off into very, very interesting emergent territory? What's up with that? Well, maybe there's genetics or epigenetic components. I wonder. So anyway, but trying to figure out what to do, how to figure out the state of the art, those are our strategies for figuring out the current state of the art, and then moving forward with what is controversial in the state of the art, given our best current evidence quality, is going to be the prospective comparative clinical trials for prospective longitudinal outcomes.
It seems like to me there's two ways you can get misdiagnosed here. So if you come in with something that looks like a dark night, quote unquote, you could be diagnosed with depression, and there's a standard issue, clinical depression. And so you could be misdiagnosed that way. Or, less often I imagine it happens, is you go in with depression and someone says, oh, that's a dark night. Is there an overlap of symptoms with these different things? And how do you manage to work out what's what?
Clearly, and that gets even more complicated when you start talking about bipolar and the spiritual high-low cycles, or we start talking about some of the strange magical effects that, some people will call them magical, other people are going to call them psychosis or schizotypal or schizophrenia, or, bipolar with psychotic features or depression with psychotic features or whatever, right? So this is where the real complicated controversy comes in. This is the tough part of the project, right? People have been trying at this one for a very long time, and a lot of smart people. So this is not new, nor is it easy. So just to be very, very honest about the challenges we're up against here. Probably somewhat easier with depression, though there's clear overlap in symptoms, right? And might you have both, even from someone who's like super into, thinking that diagnoses like dark nights or knowledges of suffering or whatever are reasonable things to do in people. They might also think, well, maybe you're also just kind of depressed because you got this, and you have a history of depression. You were depressed before any weird stuff started happening to you. And so you might get, dual diagnosis is a term that's usually reserved for, drug use overlying some other mental health thing. But I also think of dual diagnosis as emergent phenomena overlying some other just ordinary garden variety mental health thing. And then there are some people who say, no, they're all a spectrum. There's no differentiating them. It's really just all back down to symptomatic management. And so the other interesting thing is, can you do a comparison of each of those frameworks? So this is where it gets really interesting, because if you're willing to let go of your biases, that of course we must make a hard line between magical phenomena and schizophrenia. I don't know, maybe we do. And then you have other people who say it's utterly impossible. You can't possibly distinguish between magical phenomena and schizophrenia, whatever that is. Recognizing that schizophrenia was a expert opinion consensus category that came out of a long discussion out of the 1800s and German, psychiatrists leading to contemporary debates about what it actually is and isn't, and what's the range of it, and what are the criteria. Those were decided by a committee somewhere, right? It's not like it's a constructed thing, even if it has some sort of clinical and descriptive utility. And so recognizing that what we can actually then do is comparative strategies for outcomes. And this is where it gets interesting, where you could even have a group or three groups, like as an obvious hypothesis test. You could have one group of practitioners that say there's no way to differentiate any of these things. It's all the symptoms and management. And one group that says it's all hard lines and it's all DSM based and this emergent stuff is just all hokum and crazy and woo-woo. And then a middle group which says actually some may be one, some of the other, maybe some both, and you can debate where to draw those lines and how to draw them. And then you could actually do outcome studies on those three things. And so rather than having some group that just sort of pontificates about their favorite strategy and why that's the right one, maybe we could actually have data to make those decisions, which I don't think we currently do in multiple comparative outcome studies that hopefully try to replicate that across a bunch of different cultural settings. And so that's what I would actually really like, is that hard science. And so then at least if you're, choosing one of these frames, can differentiate, it's all just the DSM and emergence is all woo-woo, then at least you're basing it on something like data, right? And that's what I would prefer. Then what currently happens is not that at all, right? So
yeah, it strikes me that one of the things this project is doing is, to some big degree now, but obviously as the thing expands more and more, is giving clarity to people who basically go, well, it doesn't really feel like the thing that I've been diagnosed as, because there was this extra weirdness. There was this extra phenomenology, and people say anxiety, but anxiety doesn't usually have lights shooting out your spine.
Right.
Is one of the pieces of feedback you've got, or was one of the motivations of the project, giving people the thing to hold on to? People get diagnosed with stuff and go, oh, it's such a relief to get diagnosed. Mm-hmm. Is that one of the appeals here?
Yeah, so that quality of normalization, the quality of normalization of the possibility that what you're going through might be normal is huge for people, or within the range of human experience, or might even have some healing or transformative potential. This is of tremendous value. And so those of us who, like myself, I started out with weird energetic phenomena. I had no idea what the hell it was. I didn't even have language for it. I didn't tell anybody about it when I was a kid, and it was super strange. And 10 years later, I found people who had a relatively good knowledge of these things and could describe it and explain it and all that. And so, but once, it is hard to explain how my heart lit up with unbelievable joy at the validation of going, oh my gosh, someone else has been through this. It wasn't just a strange thing for me. And so, I have my own personal experience of how vital that validation is. And I also know plenty of people who have gotten into territory that I, from my own experience, is expert opinion level, not long-term prospective clinical trials, right? But my expert opinion is that this stuff has transformative and healing potential, even if in the short to medium term it might be weird or challenging. Right? So one dude's expert opinion on the internet, but we would like better evidence quality for that to actually do the prospective long-term outcome studies that show some of these things might have healing potential or value. And as the positive psychology people have been pointing out for years, wouldn't it be cool to have diagnoses like thriving, like, or, significant upgrade in consciousness, like, wow, increased emotional resilience, like
so much missing from the dialogue, isn't it? Not just to make people well, but to make them super well can also be a whole program.
Exactly. And so and also to tease out nuance. Right. And temporal nuance. So, like immediately what might be going on with something. So this is something I do all the time when I'm talking to people about meditation stuff, again, through the lens of my own tradition, which I realize is just one limited lens. Right. So, not that it's the be all and end all solution. And plenty of my own ideas about things may not make it through the scientific process. Right. So as we do the science, it may be that none of my maps, models, or conceptions of any of this turn out to be right. Fine with that. Right? Totally fine with that. More interested in the science than my own biases and opinions. But, from my own currently biased expert opinion, I would say that there are some things that like, ooh, that is really cool. What happens next might suck, but ultimately that might lead to really great. That is something that the clinical mainstream actually understands at certain levels. So, for example, a surgery, right? You come in with an appendicitis, might hurt. You get a surgery, it might hurt worse. And then, however we would expect from the removal of that appendix, you might do better. Though some people might do really badly when they get septic or an infection or something, right? And so we have a concept of this. Or, for example, a family member just got reclassed, which is something to help osteoporosis. And they felt horrible for days with fever and muscle aches and joint pain. It's really, but they're getting better. And in theory, it will, reduce the chances that their bones and fracture and their back collapses and their spine collapses, right? So we have this notion of sort of healing crisis or going through things that are challenging and strange that actually might lead to better outcomes. Plenty of medicines are a rough ride, like amphotericin for fungal infections. Amphoterrible is its name because it makes people just feel so god-awful, right? But it can, maybe save your life if you're septic or have some fungus growing on you from, And so in the same kind of way we get it, we just need to apply it to some of these other phenomena. So not only to be able to diagnose immediately that you might have something challenging, but also that it might have the potential for real benefit and transformation, and also to be able to tease this out. So a lot of people present with mixed pictures, where they might have gotten some really cool and amazing transformative insights, but they're also at the same time struggling. And so to be able to give both positive and negative diagnoses, on a chart would be really cool and actually much more match with human experiences, and I think be a lot more validating of the complexity of the range of what we see.
I have two practical questions because we've got you here, and I think it's so cool that we have you here where I can just ask you this. So you're talking a little bit about the ability to transform some of these emergent phenomena into opportunities for healing and for wholeness and for self-understanding and self-discovery. And you have a lot of experience talking about these things and transitioning through these spaces yourself. Is there any sort of general, I know we're talking a lot about scientific specifics here, but is there a kind of general advice of how to approach the various kinds of emergent phenomenon that we might dump into in these various contemplative practices in a way that would make them wholesome or healthy? Is there a sort of general piece of advice you would ever give somebody?
Wow, that is really hard to do. So, and I appreciate the question, right? What is the magic bullet? What is the secret sauce? What is the simple thing you could say? I mean, I do have this notion that knowledge makes a difference. Now, that's not always true. People can get into scripting and competition and comparison and striving for something that is not going on at that moment. So it's not like knowledge is always good. So I would say more knowledge with a lot of additional information about how to handle the downsides of knowledge.
Right.
That's what I would say. How to relate to the predictive problems, the nocebo effects, the comparison, the competition, the judgment, all of the things that can arise. Or if you're going to decide you go the way of no knowledge, then somehow you need somebody else there that has it, who can be watching your back, right? So that's, and helping guide you through, even if you want to go through it clean and without all the maps or tech or any of that kind of stuff, right? Yeah. So that's just a general thing, because really when I usually give specific advice to people, it's after long conversations of asking them about their goals, their risk tolerance, right? So some people are like, oh, I want to do these crazy deep dive practices and, do 5 grams of mushrooms and take a bunch of 5-MeO DMT and do a 10-month retreat and whatever. And other people are like, yeah, I just want to be a little more calm and get through having young kids and still got to pay the rent, and I can't have my brain malfunctioning or acting weird. That's not cool with my situation right now. I got aging parents, I got whatever. And so it's actually very long conversations with people about their goals, their life, their tendencies, their sense door proclivities, their aesthetics, their religious affiliations, what they like, what they don't, so it's a very complicated conversation, but I think there are ways to have those. And I also think we need specialists, professionals who have that formal training in how to do that well. And so because a discussion of risk, benefits, and alternatives, the ethics again, we're back to that, of course, is predicated on the patient's perception of risk, benefits, and alternatives, which may be sort of different from the clinicians, right? But we have all the time, people say to the doctor, oh, I'm going hang gliding this weekend. Okay. Wear your helmet. Good luck with it helping, but might help. You never know. And so, and so these kinds of things where we have to have an appreciation of what patients want and need, right? And so, because we have a lot of people saying everybody should meditate. I don't know if that's necessarily true, or nobody should deep dive meditate. It's too dangerous. I don't think that either, but giving enough information to make good choices, that's what I care about. Yeah.
I remember Ajahn Chah saying, I'm a very simple teacher. I just know a little bit left, a little bit right. And that just goes to show context is king, isn't it? Rather than being able to say, well, it's just like this or it's just like that. And again, you can start to see that I'm beginning to be a little bit suspicious of these short courses that you can just sort of jump into and jump out of, where you don't have people that you're spending time with who are able to get to know you, to ask these complex questions, to get to know if you tend to go a little bit too right, because then you can say, dive a little less for a while. Or if you're the kind of person who, you could dive a little more, but they're a little bit hesitant, then you might say, dive a little more, dive a little more.
And wouldn't it be cool if there were knowledgeable people in the community that you knew had this training and you could interact with them in a professional licensed sort of way, and they could say, hey, we have training in this, we have experience in this, I've taken care of a whole bunch of people who've been on retreats or done psychedelics or hot yoga or whatever it is that is causing this interesting stuff, and here are the opportunities, here's how to manage the complexities, and here's the weirds. Yeah. And just have that knowledge, right, as a distributed thing rather than relying on it only being in certain teachers or certain traditions or something. And we think this is actually the kind of thing that will benefit basically all of the religious and spiritual traditions, because rather than having an ignorant and semi-adversarial healthcare system despite itself, and it will also help the healthcare systems, right? Because it's not like my clinician friends went into this to be ignorant and harmful. They went into this to know stuff and help people, right? And so the EPRC project is designed to help all of these groups, the religious traditions, the meditative traditions, the contemplative traditions, the clinical practitioners, to just do what they do better and have better outcomes. Yeah, and also, like in terms of the 10-day courses, right? So a lot of them are saying, yeah, but the benefits people get are worth not telling them about it. And so that's the kind of question that is an open science question. You could study a whole bunch of people for 3 to 5 years, 10 years or whatever, who did these short course intense retreats or whatever it is, and you could just describe the range in a very neutral way, such that your concern or your question or your sense of could actually be really grounded in data. And you could say, here's the percentage that this, here's the percentage that that, and also what are the predisposing factors for various outcomes, right? So that's one of the other parts of the EPRC project, is the predisposing factors project. What are the things that are more likely to make for a good or bad trip? Set and setting, but what else? right? What are the things, is it true that people who have mental health issues shouldn't do deep dive meditation? Or maybe they really should because they need the higher dose to really get the benefits? Or in what circumstances? These are hotly debated questions that we just need better data on, right? And so my opinions are interesting, but they're not nearly as interesting as real big trials. And so that's why we need real big money and real lots of scientists who are willing to put aside their own biases, because all of us are coming to this from our own traditions, right? All of us are coming from our own biases and experiences. But can we just kind of put those aside and actually do really good science? I don't see a lot of that happening. Most of the contemplative scientists and traditions are rah, my tradition, or these traditions that burned me are bad, yeah. But I would really prefer again, I'm sorry if it's subtly arrogant to say, like, to take the higher road and to say, hey, let's really see if we can do this more openly and neutrally and have science really do what it was designed to do, which is to answer questions in a really straightforward, equanimous way.
Yeah, Daniel, this is a change of pace. But you mentioned earlier, different traditions have all mentioned these experiences to some degree, and the phenomenology kind of plays out. I'm asking this as a terribly secular Jewish boy. Does Judaism or do the Abrahamic religions weigh in explicitly on the phenomena?
Huge.
And say, well, this phenomenology means X?
Absolutely. So there's all kinds of Kabbalistic maps, right? And the deep dive Kabbalistic practitioners are very aware of these things, right? And in fact, there plenty of emergent phenomena are described in the Old Testament, the New Testament, the Book of Mormon, right? So channeled teachings, right? The Quran, this is a channeled teaching. That's emergent phenomena from our point of view. If you're interacting with an angel who's giving you a download of information, that for us falls into this category of, experiences that people have. And so, channeled teachings are, plenty of people describe channeled teachings there, and have across lots of religions. And so definitely the Abrahamic religions, and there's tons of mystical texts. So, right, we've got up here the Philokalia and the Graces of Interior Prayer, Eastern Orthodox and Catholic, and over there I've got St. John of the Cross and the Interior Castle and all these different books by Catholic mystics, for example, and then a whole bunch of Sufi ones, right? So other Abrahamic, I've got a bunch of Ibn al-Arabi and Rabia and Rumi and Hafiz and Shams of Tabriz, and there's there's a lot of these, and so this is widely described in the Abrahamic traditions. And there's plenty of Protestant literature on this as well. The Quakers, the entire religion is named for what we call an emergent phenomena, right? This sort of trembling of religious ecstasy and whatever. That's why the Quakers are called Quakers, So we've even got a religion named after one of these. So
yeah. So do you take the mainstream Christianity, say in the States? How much spiritual significance, do you think mainline Christianity in the 21st century takes?
So conversion experiences, right? Being touched by the Spirit. I have within me probably 30, within probably within 10 miles of me is what I'm trying to say. Probably 30 churches where they cultivate intentionally religious, ecstatic experiences of being touched by the Spirit, of speaking in tongues, of gifts of prophecy, of being healed, seeing the light. I mean, this is all straightforward emergent phenomena, and so I actually think we have very, very natural allies, because these, of course, are people who definitely, if they have any sense, wouldn't tell their psychiatrist this unless their psychiatrist is coming from their particular faith or one close to it and has had these kinds of experiences and could hold that with the kind of respect that these things deserve. And so these are intentionally cultivated experiences that yet would be very diagnosable if one wasn't careful. And the thing is, even in the DSM, the spiritual exemption criteria, as I called that got in the early 90s by Lukoff, Liu, and Turner, amazing work, and yet they're rarely used. So the sense that, hey, if you're having this weird thing happening to you, and yet it's considered normal in your religious tradition, you're otherwise functional, maybe that's not mental illness, except most clinicians are not that comfortable utilizing that. And it also relies on you and or the clinician having a sort of something of an encyclopedic knowledge of the full range of what might happen in your religious tradition, which most people don't. Ask the average Catholic, what is the full range of mystical phenomena that is described in your Catholic tradition, they're not going to know, and psychiatrists aren't going to know this either, even Catholic ones, most of them. And yet there's this very wide range of phenomena described. And so to actually properly apply what I call the spiritual exemption criteria, or religious problem exemption stuff, then you still need a level of understanding that is not found in contemporary clinical education in most settings. Maybe there are places where they actually train people in this stuff, but I think it's pretty darn rare.
But that's the punchline, right? Because this is common in, like, as you say, the main religions.
Sure, of course.
In the States. And then you walk up to a psychiatrist and it's like, oof, well, this seems very strange. Despite the fact it's described extensively in the text,
And has been for thousands of years.
Yeah, right. Mark, is there anything else to add?
No, I think that's great. I think we've covered everything that we meant to cover this time. Yeah.
Cool. So very quickly, if you'll forgive my shameless plug for Emergent's benefactors, if you're interested in supporting this stuff, please reach out to us at either info@theeprc.org, theeprc.org, or info@ebenefactors.org. And we would be very happy to talk with you about if you have research skills you can lend to this, if you have network connections or people you know of that might be helpful for this project, if you have ideas about how to do the science better and well and properly so that it's properly incorporated and meets the epistemological criteria of the mainstream, or if you got a whole bunch of money or even relatively small amounts of money, we are that you would feel would be properly given to this charity. It's a registered 501c3 charity. We are very happy to make sure that that money goes to good causes. We have nearly all of our operating expenses covered by some patrons already, and so nearly everything you would give us would go straight to program. Very excited about that. Please let us know. We are happy to help further this field, and that's what we're here to do. So thank you.
We'll make sure on our website also we'll plug all of those links where people can find you, Daniel. And maybe you could also give us a small package of the sorts of places that people would reach out if they're having emergent phenomenology experiences and they're needing a little bit more guidance. I'm sure there's going to be some like fast and ready links that maybe we can already be getting into people's hands if they're listening today and that's something they feel they need a bit of support on.
Yeah, there are a number of spiritual emergence and emergency networks out there. So your fastest thing is just Google spiritual emergency.
Right.
That's your quickest route. And then you'll find all kinds of resources and communities from various traditions. That's probably the fastest way to do it at the moment. And we can provide some more links.
Excellent.
Daniel, thanks, mate.
It's been delightful. Thank you so much.
Well, guys, that was the Contemplative Science Podcast, and that was Daniel Ingram. So, as always, thanks for listening, and we'll see you next week.